about 1 hour with you. And again, as during the beautiful activity of Moritz Tannast 2 days ago, we would like to include you in the voting process. And the first test question is, when you look, these are the speakers of the last session and this session, and I would ask you to vote now whom you would like to have on the podium, who of those speakers you would like to have sitting here down and discussing the cases. Who is your preferred candidate? Please vote now. Rafael Serra is pressing several times here. But I'm afraid also the Swiss guys, because they master the techniques here. I'm sure Hubert Nötzli has talked to the technician. Exactly, she's laughing. So he has promised you something to press 5 times more than the other. So I think we can slowly, 47, 48, still counting. Maybe we ask the first already to the podium here. It's Chris Peters. It's Rafa Serra. Just come down to the podium, Rafa. And Chris. Who's the next? Hubert Nötzli, Paul Bollet, Luigi Zagra, Frederic Lord. But I'm going to make it like Donald Trump. I ask the others also coming down. Professor Nakashima, where is he? Professor Nakashima, just come down. We have enough seats here. So in order to have a little bit the regional distribution, I would like to ask everyone coming down, and we have here additional 2 seats. So I can tell you who is my choice. My choice is a totally different one. My choice is this lady, because we don't care about diversity too much, and I would like to have Katharina Chiari down here at the podium. She's a professor of pediatric orthopedics in Vienna at the University of Vienna, also doing joint replacement. And I think when you come over here to Frederic Lord, this is great. Thank you very much. I want to get rid of that boring list of those old white men here on the right side, and I think it's a good decision to come up with her. So, I would like to start with the first case. First case is an 18-year-old young boy. He sustained a femoral neck fracture in 2012. It's 6 years ago. It was treated with 3 screws. You see that in August of the same year, he started to develop avascular necrosis. You see the picture 2 months later, and he came to me in June 2013, so 1.5 years after the fracture. He appeared and he asked for advice. He was extremely painful, physical therapy, drugs, nothing helped really. He wanted to study engineering. He had made his high school degree, and now he wants to study. He has a severe limp, and it's time to decide what to do. This is something, the first question from my side would be to the panel, would you have done something different in the beginning here? Maybe we start here. Paul, is anyone commenting it? Just a brief comment. Would you have done something different in stabilizing this fracture?
Yes, I think the construct's probably not the most stable in the screw position. So I think some sort of a angled plate device would be more stable.
Acetabular.
Yeah, that would have done that.
Okay. Okay, any other comment about that? I think we would all agree angular stability would be good here with whatever device, thousands of devices, classical, dynamic, cap screw or whatever, maybe a better choice. Is that agreed? Okay.
Klaus, even a better rotational reduction.
Of course. Next one. Now, we have now to decide about treatment. And I propose the following options. First recommendation is wait and see, do nothing. He's 18 years old. Next is reconstruction, for example, head reduction osteotomy, grafting, Sugioka rotational osteotomy, arthroplasty, arthrodesis, or any other type of treatment. Is there any type of treatment you would prefer out of that list, or even another one? Who would, in the panelists, just raise your hands, who would consider a restructural procedure? Would anyone? Oh, the hands go up. Let me start with the lady here before you. Let me start. Exactly. Let me start with Katharina. Do you see any place for reconstruction here?
Ich spreche so hinein. Good morning. In my opinion, this would be a case where we probably would directly go to the total hip replacement, given the age of the patient and also his plans to be active very soon. With this anatomy, I vote for the total hip.
Okay, clear message. Professor Nakashima?
Yes. So left femoral head is subluxated already, and severe collapse, and the joint space getting narrow. So we need to do some treatment in a hurry. So I think it is a right indication for the rotational osteotomy of the femoral
The
head.
right indication for rotational. Okay?
Can I
Chris,
see the lateral view?
Unfortunately, it's only that one. I'm sure you need additional imaging, MRI, lateral view. I cannot go with this guy into the detailed discussion, but you at least would consider rotational osteotomy. Chris?
Yeah, I mean, I agree. It's probably going to go on to arthroplasty, but I think you want to give these folks the best consideration that there's absolutely no other alternative. So I do think some other views, MR, what I think becomes critically important is what's the functional range of motion. Some of these hips will be almost arthrodese to begin with, and that makes the decision-making much simpler, but some will surprise you and have decent range of motion. So I think I would consider further workup before I decided on absolutely on an arthroplasty.
Okay. Now we have our opinion from the audience. I think about half would go for arthroplasty, about 1/3 would go for reconstruction. No, two guys are for arthrodesis. Who has raised his hand for arthrodesis? May I ask who would be willing to give an argument for that? Because this is, of course, a question I raised. Who did give a choice? Yes, please.
Hello. It was just to raise the question of arthrodesis. I was thinking of asking this at the earlier session, but I would like to know the role of arthrodesis because I think it's, for some cases, it's still...
Yeah, still an option. Any other one arguing for arthrodesis? My question would be, how about if this patient would not be an 18-year-old high school student? What would be if, at the moment, many refugees are coming to Germany, young ladies have the same hips, we know exactly that they will go in 3 years back from now back to their country. Would you then consider arthrodesis, or would you also go for a total joint? Any comment about that? Does the social background, geographical background...
Arthrodesis for a woman?
A woman is a bad example. Let's say is a young man. So it's a bad example. You're absolutely right. Let's say he's a young man.
Yeah, I think a young male, especially in the scenario you're pointing out, a hip fusion through an anterior approach with plating, as described by, I think, Bern as well.
Yeah, it was Gans.
And Gans, I think, would be quite acceptable.
Okay. Your remark about the woman is very good. I just asked because at the moment most patients in that age group who have really destroyed hips are coming to me are young female ladies, and I'm always thinking what happens if I do a total joint with them and they go back and have no appropriate treatment. But you would not do an arthrodesis in a woman? Really? Okay. Okay, I think it's not a good option for the most of you. Now we go to the next question. We agree that we do we have a possibility of doing joint preserving surgery, Sugioka osteotomy. Chris argued for some other possibilities, but most of you voted for arthroplasty. If you do arthroplasty, what are your recommendations? First, A, cemented or hybrid total hip arthroplasty. B and C are short stems. We discussed this morning about short stems. A short stem, B, is with ceramic on highly cross-linked polyethylene. C is ceramic on ceramic, and the options D and E are standard stems. Also back again, ceramic on highly cross-linked polyethylene or ceramic on ceramic. What are your recommendations? Cemented or hybrid total hip arthroplasty in an 18-year-old would obviously no one do. Most would do a cementless standard with ceramic on crosslink polyethylene, followed by cementless short stem, also ceramic on crosslink polyethylene, but a little bit on the close position is ceramic on ceramic. Just, I would like to have those colleagues briefly explain their personal recommendation. Chris, may you start with you? You have a big experience with young patients. You gave a brilliant talk today. What is your personal choice in this case?
Yeah, I would probably try and do a standard wedge type stem. The caveat here is the canal is incredibly small and incredibly tight, and sometimes you will have difficulty getting a stem in, and you may have to consider some reaming. The other alternative would be to use a machined type of system, like a Wagner cone or an SROM, and I don't think those would be unreasonable choices here. And then I would do ceramic on highly crosslink poly.
Ceramic on crosslink poly, standard stem. Yashuharu?
Yeah, I also choose ceramic on crosslink polyethylene for the articulation and for the standard stem such as the table wedge.
Hubert?
Because I have no so much experience with the short stem.
Okay, Hubert? You must press.
I would use short stem and ceramic and polyethylene, and not ceramic and ceramic, because I fear the stress shielding behind the very stiff metal back.
Raphael?
So pretty much the same, a standard stem, length stem with a ceramic on polyethylene. And, if we were in Exeter, I think that the response on the left would be, there would be at least some surgeons that would be cementing a stem. I think, and I just want to make a brief comment about that. Obviously, in this case, radiographically, I think a cementless stem would work well. But there are circumstances in young patients where I don't worry about using a cemented stem like a tapered polished stem if needed. So I don't think that being young should be a contraindication. I mean, the data is pretty good. I mean, in their data, the Exeter group, 20-year data with 100% survivorship really of those stems from loosening. So I think that's an option
Frederick?
as well.
I would do a PAO on the right side. But the short stem and ceramic on the first.
It's an absolute good point. He's coming with the left side and has no pain at all on the right side.
No, it's a joke.
It's a joke. Okay. What would you do if he had pain?
I don't know, but on the left hip for sure would do short stem because the
short stem
so narrow,
and the bearing.
The door A++. So
okay.
And this guy will live 60 more years probably. So. Yeah. A short stem will be easier to revise, and the long stem maybe you have some stress shielding and some. And ceramic, I'm not afraid of that. I use that for 15 years with
ceramic on ceramic, the French paradigm, ceramic on ceramic, good French experience, perfect.
The only thing I would be careful. I want to have 4 millimeters on the liner side of ceramics because this never breaks. If you have a 36 again, 2 millimeters layer, you may have some breakage.
Yeah. Paul, any place for resurfacing? I'm joking.
No, it's something you always consider in a young patient.
Even in this high amount of avascular necrosis?
Let me finish.
Okay.
I think it's unfortunate that the osteonecrotic lesion is that big because, especially with a canal like that, it would have been a great construct, but there's too much head loss there. So I'd use a standard stem. I would have the same concerns as Chris in regards to the distal aspect of the femur. And I just put a highly cross-linked with a cobalt chrome head.
Highly cross-linked with cobalt chrome head on a titanium stapler. Again, highly cross-linked poly inlay on a cobalt head on a titanium taper.
Yes.
Raphael. Tell him why he should never do a cobalt head on a titanium taper.
We've had this discussion with the Canadians for a decade now. I mean, I don't even want to start, having that discussion again. But I mean, they don't have the same, I mean, according to what I think you guys don't see this the same as we're seeing it, right?
Okay, now I know why Trump threw them out. Okay. But would you
And
agree
we're
with me?
happy about it.
Okay. But would you agree with me, Paul, that it's a higher incidence of taper wear issues when you combine metalheads with titanium stems compared to metalheads with metal stems cemented? Or don't you agree with that?
You mean cemented stems?
No. When you have a cementless titanium stem,
Yes.
and you put a metal head on it,
Yes.
you have probably a higher incidence, as the literature shows, a higher incidence of taperosis, trunionosis, when compared to cemented cobalt chromium stem and cobalt chromium head.
Or with, compared to a cemented stem?
Of course.
I don't know that data.
Okay.
Klaus, before you show the next slide, may I make a comment, please? There is a limited window of opportunity. It's limited to consider a valgus flexion salvage intertrochanteric osteotomy for the following reasons. The medial inferior pillar is intact. The pain may be coming from impingement proximally in the fractured depressed area in abduction. The way you make this decision, you have to have at least 15 degrees of passive adduction, which is pain-free. The patient has to be able to stand and walk in an adducted position and say, I feel wonderful. This takes all my pain away. You have to have a functional radiograph in maximum adduction that shows relief of the proximal impingement and good contact medially.
Yeah.
If all those criteria are met, I would have no hesitation to do a valgus flexion intertrochanteric osteotomy.
Yeah, this is a very good comment, and you remember maybe in the presentation yesterday by Michael Millis, he showed a case. I tell you why I do not do that anymore. I did about 20 cases of that, mostly young ladies, aged between 13 and 16. From my experience, about 70% of them go back in adduction, even if you do the valgusation. Then you have a dysmorph valgus, which is extremely difficult to operate with a stem, with a conventional stem, but you should consider this option. Okay, so we summarize. Most are for a conventional stem, some are for short stems, with the bearing about half and half ceramic on ceramic in the audience, about 80% here ceramic on polyethylene. I show you what I did. It was 2012. I did a conventional stem, which fits here very nicely, a ceramic on ceramic bearing. I also watched to have a layer thickness of more than 4 millimeter. I'm only afraid in those cases for some cases of making noise, but otherwise the results are not bad. We choose the standard stem, this type of standard stem, because he has in the Swedish registry, after 10 years, a nearly 100% survival. In the Australian, it's about 6% revisions. There are some publications out with young patients who show nice results with ceramic on ceramic, but I think the reflections you get from the audience are very good here from the panel. Just one short question. Who would do which approach? Only just 4 comments, not discussing why, advantage, and so on. Fredrik, what is your approach? Anterior?
Anterior, yeah.
Anterior, you again said with the short stem. Anterior with the short stem. Chris?
I would do an anterior-based approach, but I think it's probably the least important consideration in these patients.
I agree totally. I just ask you because I looked a little bit in the literature, and if I'm right, you switched from the mini posterior, Chris. I looked in the literature, and I seem to remember you switched from the mini posterior to the mini anterior. Is that correct?
No, I don't. Well, I don't technically do a direct anterior approach. I do a Watson-Jones-based approach, which
okay.
I'm not sure that it functionally makes much difference, but
Okay.
I think you can get a very good result with a mini posterior approach here or an anterior-based
Okay,
approach.
Luigi?
The implant exactly the same that you did, CLS, ceramic on ceramic.
No, it's the approach.
The approach,
One-word
sorry, it's a
approach.
posterolateral approach.
Yashuharu, approach?
Yeah, I'm using a posterolateral approach for all the patients.
What is your standard approach in Vienna, Katharina?
Direct anterior or Watson-Jones, depending on the surgeon's preference.
I don't agree with the approach, because this guy will be revised when does the others. If you make first case anterior approach and make the revision to the anterior approach, it will be perfect even after the revision. I don't think you can do 2 or 3 revisions to the posterior approach with a perfect result. By experience, I know of patients who have the 4 revision through the anterior approach, they are still perfect. The approach is like a zip approach. You just open and close, it's not a problem.
We have some guys in the audience here who really doubt, and I'm one of those, that you can really do good revision surgery through the direct anterior approach, but this is a discussion we won't open now, because we would not end it, I think. I have another question. What is the patient-related outcome? What is the satisfaction in this guy? He belongs to the Y, generation Y. How is his satisfaction? Will he be, and I ask you to vote, is his satisfaction and his outcomes better when compared to elder patients? Is it the same as in elder patients, or is it worse than in elder patients? Because I agree with the panelists here, the approach does not really matter, except some have other opinion. Maybe the material plays a role, but the most important thing is how is his personal satisfaction. What do you think? Better when compared to elder patients, the same as in elder patients, or worse than in elder patients? We have obviously a very, very good trained faculty which knows a lot about the literature, because I show you briefly the literature. We have here a meta-analysis in 2013 which tells us what every one of us knows. Following surgery all showed improvement, but they did not say something about the age. We have a study from the Swiss Arthroplasty registry which says that 8 years post-op, the health-related quality of life in younger patients is better than in patients over 30 years. I show you our own results in Dresden. We have a registry with about 2,000 total hips analyzed for that question. And we see the blue lines are the EQ5D, health-related quality in different age groups, below 30, 30, 40, above 80. And we see they are all about the same before the surgery. And the gain is really high for most of them. But when you look at the end result, the younger patients below 30, they are not as good as the patients in between 30 and 40. And then it goes a little bit down. But the big question is, what is normal? Which health-related quality of life is normal? And when you compare it to the age standardized value, you see, indeed, the young patients are not reaching the average value of health-related quality of life. The older patients, mostly of them, are even better with the total hip than the age-matched control. It's an interesting finding, and we have some publications here. Where's John? John is where? John, why are you not on the podium? I also asked you to come on the podium. You have been in that, close to that group which published the results from this study, and they said 3 to 20% of patients between 80 and 60 years have moderate to severe pain. Well, what's your perspective about young patients and satisfaction and PROMs?
Yeah, I think they do extremely well, as you have shown. I do think they're a different patient population, and when you take the very young patient population as a whole, a lot of them have other disorders, or they have syndromes and that kind of thing. So their function preoperatively is quite different than the normal peer population. So I do think they get excellent relief of discomfort, but their function may lag behind their age-matched peers.
Yeah, Chris, you have very nicely shown us today in your publication the results. Also, your publication here says below 30 years, 5 years after total hip arthroplasty, the patients have higher physical function, but lower mental health. What did that mean in your cohort?
Well, I think what we're seeing, I think it's important to get pretty granular here, because I think what we see is, for instance, the teenage population, they often have very, very severe dysfunction of their hip. Sequelae of Perthes and AVN, and these are very, very destroyed hips. But then we start to get into the 30-year-olds, we start to add into that group for instance, females who may be coming to see us for consideration of a PAO and they're just not quite, their joint's not quite good enough to do that, but they get a hip replacement and their expectations are dramatically different than that, for instance, that teenage person who has really bad AVN.
Okay. Katharine, any other opinion from you or confirmation?
I think what plays a big role here is, as we heard yesterday, is the individual patient's expectations, and I think it's very difficult in those statistics to show this, and this might also explain this diversity, because we know kids who can't walk and are suffering for a long time, I think they benefit initially very much, but on the long term, then there might come up this difference between the age groups.
I took the criticism of Chris. He said we are getting pretty much granular here, and I'm going a little bit faster now. This is the next case. Carmen, 33 years of age. She had her first total hip at age 20, 13 years ago on the right side. It was a girdle stone resection due to periprosthetic infection. She cannot tolerate pain and limping anymore. She comes in the age of 33. She has this type of oblong defect, which is it's no pelvic discontinuity, as you see here. It's a big and large oblong defect. She has a normal body weight. She has 2.5 centimeter shortening. What would be your options for reconstruction? How would you reconstruct the acetabulum? I'm only interested in the acetabulum. Would you do a reinforcement ring with bone graft, which is B? Would you do impaction grafting and a cemented cup? Would you do a jumbo cup or an oblong cup? Would you do a cup and metal augment? Would you do any custom-made cup? What's your choice here in the audience? 33 years, 2.5 centimeter of shortening, and an oblong defect.
How long time after the Girdlestone?
It's 13 years, 13 years. Just in between, would you do biopsy to rule out persisting infection? Would anyone do a biopsy or only aspiration or nothing? Short comments, please.
So we've looked at our long-standing girdle stones, and there's nothing really to help us other than intraoperative pathology.
Okay. Would anyone do a biopsy before?
What was the reason for the
periprosthetic joint infection? 13 years ago.
I would do an ultrasound, and if there is fluid in the joint, I would aspirate.
Okay, thank you. So,
should get a acetabular and sear.
Okay. So we see a clear favorite is reinforcement ring and bone graft, followed by cup and metal augment. May I ask the panel just to raise your hands? Who would do in this case reinforcement ring and bone graft? 1, 2, 3. Who would do cup and metal augment? So it's 5 over 3.
It's American.
Not only American. It's also Central European, I think. But we will see. She has another question. She has 2.5 centimeter of shortening. You see, we are planning for cup and augment because this is, as data shows, a nice solution. She has on that side 2.5 centimeter shortening. We are planning for a lengthening of 4 centimeters. Do you think this is okay? Do you think you must do anything about that? Would you do less lengthening? What's your opinion?
I think a couple of things. If you go back to the pre-op on the lateral, you can see near the ischial spine, there's still a good amount of posterior column. So if you don't go too big, you got to start with a small reamer and not try to match defect, because you can actually, like a dysplastic hip, may get enough of a deep socket to have some sort of AP containment and then minimize your bone, but sometimes you still need the augment. And so that's and I would use a posterior approach for that to get that visualization with screw fixation, plus or minus an augment. That would be that. And on the femoral side, I'd probably use antibiotic-loaded cement, because risk of persistent infection, or I think a group in Stanford showed that bacteria can actually hide in the bony lacunae. So I think that would be kind of a hybrid construct.
Okay. Would anyone consider totally different things from the panel? Not. Okay?
No, but I think this is a case where you have to go in knowing that it's going to be a very, very difficult case. And lengthening is something that you can tell that you're probably gaining a little bit, but I would never promise a patient that you're going to get 2.5 centimeter.
Yeah, she would absolutely hate any lengthening at all. She is not liking lengthening. So we did, as you see here, we did the cup and augment. which I agree with Paul. We started with reaming, no additional defect in the primary acetabulum, a big augment here. We did intraoperatively realize that we had a lot of difficulties to get her down. Had a lot of tension on the already scarred ischial nerve, so we did a shortening osteotomy, as you see, with about 2 centimeters. This is the postoperative image. This is the image 10 years later, and you see she received a total hip on the left side just a few weeks ago with the same stem. You see the stem here. It's a cone stem, a Wagner-type cone stem, and this is the trabecular metal augment. I just go briefly into the literature. We have several options for trabecular metals and other alternatives, cup and augment. This is the technique. Most of you, I think, are aware of that. And the results of this technique, which are at the moment available, mostly of them are already approaching 10 years, are very, very good. So I think it's not only an American solution, it's also a widely practiced solution in Europe at the moment. Frederick, you did propose something other. Just tell what you...
No, because I have no experience with this.
Okay,
So that's only... But I think it looks perfect.
Okay. So we go to the next case.
I have just one question. What kind of approach did you use?
This was a previously lateral approach. I took the same skin incision, but was prepared, depending on the situation I find. If I have a totally defect or missing gluteus medius, I would go into the same window. If the gluteus medius would still be preserved, I would go through the lateral incision over a posterior approach, and this was which I did. What would be your advice?
I would do a trochanteric osteotomy, so you are prepared for everything, also the lengthening or shortening. And you are at the same interval, so and you are not hurting the musculature.
Okay, I think it's an interesting option. Any comments?
Yeah, and I would have also from the get-go done actually an extended trochanteric osteotomy, a little bit longer osteotomy to get a little bit more bony, because if you do a short one, then you have to shorten, then you won't have bony apposition. So I would do a longer osteotomy.
Okay, we go to the next case. Case 3, it's a young patient, 32 years of age. You see he has a pseudo-achondroplasia. It's a short-limbed dwarfism, early osteoarthritis. He has painful both hips, painful both knees. The knees are unstable. He has received multi-level osteotomies. He is about 1 meter and 20. He has severe hip pain on the right, more on the left side, and instability on both knees. What is your advice? Ask to the panel, just one word, what would you do preoperatively in order to plan? Just one word.
Who's the other guy beside him?
Pardon me?
Who's the other guy? I'm scared of the other guy. I want to know more about that guy.
The tall one is the surgeon. Klaus, you need a clear pre-op plan, because maybe that you don't have the size for this guy, and you need for a custom made for the company.
What do you mean by clear plan? How are you executing it?
Start with the we do a two-plan.
Digital planning.
Digital planning with the
Chris,
magnification.
Okay, Chris?
Yeah, I wouldn't do anything else. I mean, the short stature surgery it's very, very difficult, but most of the time, for instance, SROM now, you can get a 6 millimeter stem.
Only one word. Planning, yes or no? And
no
if
planning,
yes,
no planning. You
no
can do this
planning.
with off-the-shelf components.
Okay, no planning off the shelf. So we have one planner, one non-planner. Raphael?
I would certainly plan with the standard computer.
Two planners.
However, there are very small patients where it's not a bad idea to get a 3D model and actually do the surgery ahead of time on the model.
Okay. Yeah. Just one word. Planning, no planning.
3D planner.
3D planning, Paul?
Planning, make sure it's
planning.
CT scan.
Yeah. CT scan and 3D planning.
But I think it's interesting to see how internationally there are several countries who are not used to planning. Others are forced to plan. We must, for example, do it. So we did a CT and, of course, a radiographic planning. In the CT, we measured the acetabular width here, which is the maximal width is 42 millimeters. The maximal diameter here is 12 millimeters. And what is now your choice of implants? Please, the next question. Would you go with a standard cementless stem and cup, a standard cemented stem and cup, standard hybrid, or would you go for a custom-made cementless, which is at the moment very popular, or other solutions? I think we can slowly close. Standard cementless stem and cup, followed by custom-made, and followed by standard hybrid. We are also doing planning. We try to get with a reference, a very good digital planning. We came out with a stem size which is 13, but it's exactly the smallest size the company has available. So we ordered one size and two sizes smaller just to be prepared for surgery. And the cup size here in planning was cup size 40. And I also asked for smaller cups, which they have regular. Just again, one word about the approach. He had a previous previous femoral osteotomy. What is your approach in this patient? Frederick, anterior?
Probably.
Probably, Paul?
Posterior, because look, he has no canal on the CT.
Posterior, Luigi?
Posterior.
Posterior, Hubert?
Trochanteric osteotomy.
Trochanteric osteotomy, Raphael?
Posterior.
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 Okay, most posterior, one with trochanteric osteotomy. This was our choice. Intraoperatively, we ended up indeed with a stem which is one size smaller than the available stem, so it was good to have the implant produced, although it's, of course, expensive. The cup was in size 40 as planned. Paul will be happy. It's now a metal head, metal on poly, 22 millimeters. I'm concerned because I have several patients who have trunionosis, not with 22 millimeter heads, but with larger heads when you put a metal head on a titanium stem.
Can I have a question?
Yes.
How long does it take to get this stem? Because I'm waiting for the same situation for another case.
Yeah,
How long?
6 weeks. Yes. Just the literature about these cases in dwarfism. We have 1 10-year survival here. You see the controls and the dwarfs end up here and 10 years with same survival of 86% in this study. In this other study from Germany, we have about 93% survival at 5 years. So it seems to be, of course, a little bit lower, and the complications are a little bit higher. This is our preferred type of stem for these patients. It's a tapered cone stem, Wagner cone prosthesis, which is completely free regarding the femoral antetorsion, and we use it in a lot of situations like here because it has a high versatility and can be used in a lot of critical situations. Next case. This is a 51-year-old lady. She's a secretary, a very attractive and nice girl. Regular body mass index. She has had a varization osteotomy in childhood. No leg length discrepancy at all. She has severe day and night pain on the right side, pain relief after intra-articular injection. Just Luigi and Hubert, what is your implant? What would you choose here? Luigi?
Cementless cup. And
let's only talk about the stem.
Let's only talk about the stem. I need a lateral view. I need a CT scan. This can be a conical, even modular stem, if the size is okay, or it's Zweimüller type.
Or it's?
Zweimüller type.
A Zweimüller. Hubert?
I would also like to see another plane, and it could be, and then it depends on the planning, it could be a short stem.
Okay, we have, meanwhile, the response of the audience here. Was it the last? It's, I think, the last one. No, it's the last one. Our question here, again, in the audience, choice of treatment, who would do, I added here, joint-preserving surgery. Who would consider joint-preserving surgery? 51 years of age, secretary, any thinking about that and doing extended imaging? Who would do a standard stem? Who would do a standard stem with osteotomy? And who would do a custom-made stem? So several people are considering joint-preserving surgery. Anyone in the panel considering joint-preserving options in a 51-year-old lady? Pain relief after intra-articular injection, severe day and night pain. Anyone joint-preserving? No joint preservation. Okay, so those in the audience who have voted for joint-preserving surgery would critically listen to the experts here who would not recommend it. most of the audience recommends total hip arthroplasty with a standard stem here, and I follow just the rules. We have no MRI because I also did not consider joint preserving, but we made a CT in order to get an idea of the deformity, and I think the CT nicely shows that there is not really a place for joint preserving surgery. Does anyone from the people who voted here, would anyone with these images go away from joint preserving surgery and go to a total hip right away? Will probably not show.
I think in this situation, an MR would be more useful because you could see if there's bone cysts and really kind of, if you're possibly considering that, that would be more useful.
Yeah. Okay. This is the oblique view which was asked by Luigi and Hubert. Luigi, you said you will do any type of Zwei-Müller stem, or do you stay with this opinion? Not now. Okay.
Not now.
But I must be fair, you said you need a second plane X-ray, so it's fine.
Sure.
So, would anyone change his mind from the audience here? What's your recommendation? Very briefly, so let's start with Rafa. What is your recommendation?
I think it's pretty clear that there's a biplanar deformity there. I mean, I would still template this and see if I could get in a short stem. The position of the trochanter is also going to be important to decide whether you're going to be able to get a short stem or not, or even a straight stem, but probably a short one. Short banana type stem. If I can't get that, then you're looking at doing an osteotomy. And I mean, in a young patient like this, I think that an osteotomy would be a very good...
A osteotomy would be a very good
option for
osteotomy.
them.
So osteotomy and then do a conventional straight stem in that case.
So I would use a modular stem.
Yeah.
Similar in the way that I would do a subtrochanteric shortening osteotomy. So I would use, I'm going to give you the name because I think
with
it's...
the diaphyseal fixation and a good...
Yeah, the flutes
grip.
distally like an S-rom and then above.
Any other significant other options? His opinion were do a good planning, start with surgery, if it's necessary to do an osteotomy. Any significant other options?
What's her range of motion again?
Oh, I do not really know that. She has not an extremely bad or extremely good range.
Not too much of an
average.
inflection?
No.
Because, I mean, a bit out there, but this could be a reasonable in terms of because of reconstruction to do a ceramic on ceramic resurfacing. Preserve the bone, and you don't have to do an osteotomy, and good bone fixation.
Okay, we will come back to that. We did a planning for an osteotomy, as you see, correct the varus. Then with the corrected varus to do, you see we have a favorite prosthesis here, the cone prosthesis, but you can of course use other prosthesis which has here a diaphyseal fit as well. Intraoperatively, we started with a starter instrument which can be used or which belongs to a the special type of short stem. And you see, interestingly, in spite of the big deformity, it ran down very well. So we continued, and at the end, we did not a typical short stem, but a cementless stem, as Hubert Nötzli was showing today. This is the 2-year result. Do you think, Hubert, that this varus, which she has, she is absolutely pain-free at 2 years, is back at life and profession, no problems at all? Do you think this varus and this somewhat strange situation will she run in any problem in the future?
No, I don't think so. Varus is very well tolerated. The problem is more the very big offset. Very big, so you have a very long handle there. But a little bit varus is really, it's absolutely no problem with that one.
To be honest, I was not happy with this post-operative X-ray because I thought, oh my God, every time when I look at it, I will have problems. But she was used to that situation. I did not increase it too much, and she's absolutely happy. Okay, the results.
I'm more concerned about the lateral view than the varus in this case.
You are
to
more
plan than
concerned
to do the
about
surgery.
the lateral. To plan, okay.
Yes, the other plan, because you are going against the cortex.
The big question is, we have, meanwhile, as Hubert Nötzli showed us, good results with this stem up to 10 years, different meta-analysis and such things like that, but we do not have at all results in deformity. We have some case reports where people advocate for short stems in such situations, but we have no clinical and material available, so we do not know what will happen. Clinical results and patient satisfaction in total hip replacement after femoral osteotomy. Just I scored the literature. Most authors say there is longer surgery, but the outcome is not totally different between normal patients. I doubt it a little bit because most of the osteotomized patients, I do have a little bit less good outcome. Now we have two cases together. These are two interesting guys. This is a 53-year-old video cutter. He used to be a former professional soccer player. You see this picture 30 years ago. And this is a 78-year-old retired professional tennis player, and he's still playing tennis very, very ambitiously. Karl, who is a friend of mine, I operated him 16 years ago with his resurfacing in 2003. He has an extremely satisfactory situation here, is fully active, but is now a problem on the left side. This guy here, I also operated him 18 years ago on the left side, extremely happy, no problems at all. He is a video cutter and asks me, what would you do now? What is your recommendation? This guy comes and says, I want a hip resurfacing on my other side. If you don't do it, I go to another place.
Go.
John or Paul, we would probably do the serum ions, check the serum ions in both patients. They're absolutely normal, no serum ion elevation at all. And now the question is, I ask the audience for voting. Question A is resurfacing for both patients. B would be resurfacing for the young guy, Karl, but standard hip for the old tennis player. This is the other way around, standard total hip for the young one and resurfacing for the old guy. The third option D is standard for both patients. Any other options? John, you have published a little bit about resurfacing. What would be your choice here in those two patients?
My personal choice would, I've done resurfacing in the past. I've changed over to total hip for several reasons. So my personal choice would be, I would offer total hip arthroplasty in both of these patients and talk to them about the reasons. At the same time, you want the patient to be happy. So for this 78-year-old who's apparently quite active, healthy, and is very happy with his resurfacing on the left side, a discussion with him, I would be amenable to doing a resurfacing on his right side, if he felt strongly about it, which it sounds like he does.
Okay, because what you raise is, I think, extremely important, that the expectation of patients, once you convince him to do something other, he probably will, with the mildest problems, not be happy. Any other comments from you, Paul?
I think the approach is perfectly reasonable in terms of stability, risk of reoperation, and if he's done well with one side, I think there's no, as long as you have a good implant that has a good track record for resurfacing, that's perfectly reasonable.
Both
option.
patients? Both patients?
The 53-year-old, I'd be worried a bit about the femoral bone quality, but I would say, look, I'll prepare the head, see what I'm left with, and if I can't do the resurfacing, we'll just do a total hip. But that's how I would approach both patients.
Raphael, you have also some publications done about hip resurfacing?
Yeah, so my choice today would be a total hip replacement for both patients. I would not do a hip resurfacing.
A total hip replacement for
But
both
whose
patients.
choice is it? You said my choice. Is it the patient's choice or your choice? How does that work?
Well, it's my choice.
Yeah, it's your choice. Okay.
And if he refuses,
And if he does, and I've had patients, I mean, I did hip resurfacing, I've had patients that come back and ask for the other side, and if I can't convince them, then they'll go, I send them to 2 or 3 patients, surgeons in the U.S. that continue to do hip resurfacing. But I don't do it.
Okay.
I mean, do you worry at all about the cup? The stress shielding that's occurring around that cup?
No, there's good RCT data from Job van Sosante that does a randomized trial showing that the cup stress shielding is not an issue at long term, and the gait actually is better with resurfacing compared to total hip. So I'm not worried about that.
We ask the audience here, most would do a standard stem on both patients. 6 would do a resurfacing for both patients, like maybe Paul. 3 would do a resurfacing for the young guy and a standard tap for the old guy. 6 would exactly do the other way around. Like John said, 3 voted for others. Is anyone who voted for other procedure, would he tell us what that would be? Any advice? 3 guys have voted for any other procedure. No, really. Okay. I asked most of them exactly. Mazar, where's Mazar? Have you ever done hip replacement? Hip resurfacing?
Yes, we did quite a number of ASRs, and the females all fractured their necks. The ones that worked well was the femurs that were very large. So I'm not surprised that both did well with hip resurfacing. However, at this day and age, I'd recommend a cementless.
Okay, cementless standard stem. Okay. We know the literature, a tendency to improved gait, function, and satisfaction in resurfaced patients on one side, but on the other side, you have the risk of adverse reaction to metal, of course, and you must balance that risk. My biggest concern in these satisfied patients is that they, when they come back with one really happy resurfacing side, they often want the other side, and it's a problem to convince them to go back. Short comment, Masa?
Short comment. With the new technology, large size ceramic heads, like a 44,
okay.
I tell my patients that they'll get a result almost as close as to a resurfacing.
Thank you. This was what I did.
Yeah, but
I
there's
did
17% incidence of squeaking with large heads.
17% on squeaking. So I hope this will not be a squeaker, and he cannot be a squeaker. This was my choice. On the young guy, I performed the short stem in a situation because he was very happy with that and is okay. In the old guy, I indeed did resurfacing. It's just 3 months post-operative. At least he did not fracture his neck in that 3 months here. We will see what happened. What would you do in this case? 56 years of age. He has an intramedullary nailing since 40 years now. You see that 2 guys have tried to remove the nail before. You see all the metal here. What is your choice here? What is your recommendation here in this patient? Mazar. Just one word, not a big discussion.
This would probably be the only case I'd recommend a surface replacement.
John?
That's an option.
Would you do a hardware removal, a third trial?
Well, I'd like to know who tried to get it out and what they did to try to get that nail out.
Okay.
And we obviously need X-rays of the remainder of the femur so we know what we're dealing with. But yeah, I would certainly contemplate that. That would be plan A. And if there's something that I think is really something we can't get around, then a resurfacing would be the other option.
Okay. I was a big resurfacer 10 and 15 years ago. I decreased significantly, but this was indeed a case where I did a resurfacing because there was no chance to get this nail out of it.
And so what did you do? So in this case, you had a well-functioning total hip on the right side, and you didn't have qualms on giving him another implant?
I don't
in the sense that the case before you had a patient with a hip resurfacing that was happy, and you said that you were struggling with giving him a total hip or the other. This is the opposite. He's got a good hip replacement probably, and now you're giving him a hip resurfacing.
Yeah, I'm not aware of any possibility to get this nail out of the femur without destroying the femur totally. So I very seriously discussed it with him. I said, you are 56 years old, you have a certain risk of problems which will come, they are low. According to our database, we have 1,000 patients in a very good followed database. In male of his age, I can give him a survival perspective of 92% of 16 years. This is our data. And 5% of them have metallosis. So with that data, I can recommend it. Case 7.
What are you doing when it fails?
When it fails?
Then you are retired.
I will show you next year, Hubert.
So now,
I will show you next year. So who of you are Europeans? Just raise your hand. The Europeans raise their hands. The non-Europeans raise their hands. Non-Europeans? Okay. In Europe, we have a big deal with the medical device regulation. Who of the Europeans who raised their hand? Only those are voting, please. No, all can vote. Question is, next question. The European Union has introduced this medical device regulation, and we expect significant changes from May 2020. Please vote if you are practicing in Europe and well informed about the consequences. Please vote if you are practicing in Europe and not informed about the consequences, and please tell us if you are practicing outside Europe. So I think we can stop it. We have 2 surgeons in the audience who are European and very well informed. It's raising up to 5. We have 31 who are practicing in Europe and do not know too much about the MDR. And we have 8 outside Europe. So mostly are working in Europe and do not know what is coming up. I can tell you what is coming up, but let's first have this case here. He's a 31-year-old guy, had his first surgery in 1992. Paul, you will be happy to see now what happens. In 2 years later, he has this situation, and you note this picture is already 12 years after his first surgery, so well done, over 15 years, satisfaction. Then he comes back in 2012, and he has a big progressive osteolysis. You see that the CT scan is here. Implant and alternative implants are not anymore available. What could be the reason for osteolysis? Just one word. Rafa?
Looks like there's a little bit of polywear.
Polywear. Any other reason for osteolysis?
Multifactorial.
Multifactorial.
Isn't it a metal? Isn't it a metal on metal?
Metal
on metal, 28 head, and
Okay.
they typically come with
Metal on
8.
metal. That's the reason why Paul said multifactorial.
Is that a metal
It's a
metal? I didn't
resurfacing.
know that.
Okay, it is indeed metal on metal. You see it.
Oh, that's what you were telling me before the Metasol. Yeah.
Those are the typical
that-
cases. They come back after 15 or so years, and then the abductors are gone. You have big cysts and everything because they have a very severe metallosis.
This is the reason why Paul, he's a smart guy, said it's multifactorial. He immediately realized this can be polyethylene, this can be metal, this can be a taperware, what he never sees. So it's everything what can happen here. So questions to the authors, to the audience, please vote. Wait and see. Full cup revision, take that cup out and put a new cup in. Isolated removal of the inlay, put some grafts here in the osteolysis and cement a new inlay in, or any other options. Who would do? Next question, please. Please vote for the next question. No, this is not this is the wrong one. The next question, please. Skip keine mehr. Okay, so this was obviously not uploaded. Raise your hands, please. Who would do a full cup revision, take this cup out and put a new cup in? Who would do that? Is he in pain? Is he? Is he in pain? Mild pain, not a lot of pain. He just comes for a routine control and has a mild pain. Who would do complete cup exchange? Who would take the inlay out, graft the lesions here, and cement a new inlay in? Okay, most here. Who would do any other technique from the panel? Any other option? Hubert?
Something very important. In those cases, you have to do an MRI and to see how big the lesions are.
Yeah.
Because you have to know how much pseudo-tumor you have, because it limits your possibilities, and you have to do much more grafting and stuff like that.
Yeah.
It's difficult to see on those. It's really mandatory to have additional exam.
We only did the CT at that time. It was 2012, which also helps you to determine the ARMD, the pseudotumor. He had no pseudotumor at all. He had just the osteolysis. So we go to.
I have a question before you answer. So I'm not aware of this cup. I don't know the track record. But what is the track record of this cup? Is it a good cup? I mean, the fixation.
It's a very good cup.
So then that obviously is important in your decision making as to whether you're going to leave the cup or not.
I left the cup, as you see, grafted the osteolysis all around, and we ordered with the company a custom-made crosslink poly inlay Today, probably I would cement an inlay in it because it's cheaper. This custom-made inlay costed more than the whole reimbursement we get for this procedure.
Yes, but Klaus, he's 51, so you did a good job.
He's 51, but again, this polyethylene liner costs about 4,000 euros,
I
you
agree,
get for
but
the procedure.
when you cement in a 51, it's not
This
the
is
same.
the result. After 7 years, it's okay, and it's worth the money. So in summary, and we are at the end now, the medical device regulation, for those of you who don't know it, first point is from May 2020, we will have a severe impact of this regulation in Europe. We have to do substantially higher administrative work. We have not anymore probably a lot of implants available from May on. Some people say 20% of the products are taken off the market, so you have to ask your company because they do not get their whole portfolio certified in this time. So they will take products you use off the market. Ask your company how the status is because you will have a very bad situation if you are not with that. And very cheap implants on the market in Germany, in Europe will disappear. And we expect the pharmaceuticization of the implant market because all the small companies probably will go bankrupt. They cannot afford this huge administrative burden, and we will probably end up with a few larger companies who are handling all this situation. Finally, I would like to thank all the panelists for their great input, you for your support, and thank you very much for this case discussion.